Right. I think people are still joining in, but in the interest of time, I think we should kickstart today's proceedings. Once again, welcome everybody, and thanks to the Medtronic and the Parkinson's website for making this webinar possible. We are both, part of the movement disorders team in Sri Ramachandra Institute of Higher Education and Research. Dr. Vijay Shankar is a fellowship-trained movement disorder specialist, and I am a neurosurgeon with special interest in functional neurosurgery. So this webinar is aimed more at the general public, probably the patients or caregivers of patients who suffer from conditions that may benefit from DBS. Now let's start at the start. What is DBS? DBS is deep brain stimulation. It is a pacemaker for the brain, just like the cardiac pacemaker is in the chest and it sends in current into the heart. This pacemaker in the chest sends in impulses through these slender wires into the brain, into deep areas of the brain. Depending on which area of the brain the wires project into, the kind of diseases that it can help. Is the audio playing?
It's also not like
so shackles or a straitjacket to me. No, there's so many things that have been taken away with it. I can't write. I can't eat by myself. I drink out, travel more. Little things that people just take for granted. That's the non-essential traveling gets out of the box and grabs you.
Mark's tremor is caused by irregular. He had to give up his job as a heating engineer. Mark wants to have surgery where doctors at the Walton will implant electrodes in his brain. They'll use a radical technique called deep brain stimulation. He'll be awake during the operation. Mark is about to have one of the most technically demanding operations performed at the Walton, deep brain stimulation.
It's Mark with a C. Roberts.
Just to tell you about the stages of the operation, tomorrow will be stage 1, which will be with you asleep. Sticking about 5 screws on the top of the head and getting some scans for you, MRI and CT scans.
Okay.
So after the operation, we need to try and, you need to make sure that the screws don't come out.
Yeah.
On Wednesday, what we do is in the afternoon, take it out of theatre. So what we do is give you local anesthetic down there. So we'll numb the skin, but we'll be aware of whatever's happening.
Yeah.
And we'll go and put the electrodes down. All right.
Yeah. I just want rid of that.
This has been a buzz of an exciting moment, knowing that, it's the big step to what he's been waiting for so long.
If another typical operation has about 10 or 15 different steps, this probably has 10 times the number of steps, and each step is very critical because we're trying to deliver an electrode into an area with dimensions in the millimeters. So every step is important, and every step, if it goes wrong, can wreck the whole operation.
Scalp to drill a hole through the skull, ready for the electrodes.
far as making sure that he's got the entry point and the target perfectly lined up.
Target, the team send different currents through the electrode to test what voltage is going to best control Mark's tremor.
Open close as fast as you can. Yeah, okay. Take your index finger and touch your tip of your nose and back as fast as you can. Breathe with this. Good.
So there, as you can see, the results can sometimes be pretty dramatic. So you can see on the operating table with the patient awake that the shakes that he had in his hands were immediately stopped by the electricity that is delivered in there. Now we've tried to make this webinar a bit interactive instead of one person droning on all the time. So now let me put Dr. Vijay on the dock and basically ask him which are all the conditions for which DBS can be considered and where DBS can really help. You're muted. We can't hear you.
Sorry. Thank you, sir. First, I would like to introduce myself. I'm Dr. Vijay. I'm a neurologist and a movement disorder specialist. I was straight from Toronto. Toronto, as you know, that Toronto is one of the best places for the world for movement disorders and DBS. So now, after joining with Vishnu and Ramachandra, we have started our movement disorder program, and our program is going to be the first, one of the state-of-the-art movement disorder program in Tamil Nadu. So our team is going to start another program probably after a COVID lockdown. So we are going to start the program. Good. So coming to the question, what are the conditions we do DBS? So the first and foremost is Parkinson's disease. So we do DBS for Parkinson's disease, dystonia, tremors, and there are several types of tremors and several types of dystonias are there. And we also do DBS for obsessive compulsive disorder, epilepsy, and also like anxiety, memory loss. So many conditions nowadays we are trying DBS. So initially, first like a couple of years back, we thought DBS is done for very few disorders, but now with the evolving science, we are doing DBS for several conditions. So what do you think, sir? Do you want to add anything?
Yeah, that's sort of a whistle stop description of where all DBS can be beneficial. Now, before we delve into that, can you enlighten us as to what is Parkinson's disease? That's probably the number one condition for which DBS is done in India. So what is Parkinson's disease? How do we diagnose it and things like that?
So, as we know that Parkinson's disease, one of the commonest degenerative diseases, can I show us a slide just to be useful for whoever who is attending? Just 2 seconds. Okay. So the patients can have this is a normal brain. If you can see, this is the normal substantia nigra, which produces the dopamine. You can see the yellow color pigment. But in Parkinson's disease, the substantia nigra is slowly degenerating, and dopamine is not secreted enough. So in a normal healthy patient, you can see the substantia nigra with lots of dopamine, the black color pigmentation. This is for a normal patient, so it secretes normal dopamine. But in a Parkinson's disease, the substantia nigra, the dark color pigmentation is lost. So the dopamine is not secreted enough. In another picture, I can show you this one. So in a normal patient, the dopamine is secreted enough so they can have a normal movement. In a Parkinson's disease, the dopamine is not at all secreted adequately, it is less secreted. So they will develop tremors, slowness of movement, and rigidity. So one of the commonest features, what we call it as the expressionless phase, what we call it as the tremors, rigidity, slowness of movement, and postural instability, like they will have lots of freezing, or they can have lots of falls. This can occur in moderate to severe Parkinson's disease. Like what, like when the disease progresses, initially, when you take 3 tablets a day, the patient will have a very good benefit. But when the disease progresses, the 3 tablets is not enough. If they are taking a tablet every 6 hours, usually when the disease progresses, the levodopa will work for 3 hours, and the next 2 or 3 hours, it will not work. So they will have severe off period. Off period means they cannot move, they have lots of tremors, lots of freezing, rigidity. This is what, when the disease progresses, troubles them. So at that time, they need to take extra tablets like 4 tablets or 5 tablets, like add on like pramipexole or sertraline or other medications are required at the time. So it is very, very important for us, for our patients to monitor whenever they are taking the levodopa, like if they are taking the levodopa at 8 o'clock, something like this, they need to monitor when the levodopa is started to act, how long it is acting. Like if they're taking at 8 o'clock, the next dose is 1 o'clock, means how long it is working, and whether during the off period, whether they are able to do their work or not, or they require any support. And how bad is the dyskinesia? When the levodopa is more, they can have dyskinesia. So is the dyskinesia are mild or moderate? They have freezing of gait or falls during the off period. So coming back to the question, how to diagnose the Parkinson's disease? So most commonly we diagnose Parkinson's when they are having tremors, rigidity, balance problem, or slowness. Usually the diagnosis is like clinical diagnosis with the history and physical examination. We diagnose the patient, but sometimes with the sometimes some other conditions also mimic, like present like a Parkinson's disease. So at the time, sometimes like a drug induced Parkinson's disease, or sometimes patients we can see with the essential tremors or something like that can present like mimic like Parkinson's disease. So in that case, we prefer to do a DAT scan. So the DAT scan will be useful to diagnose the Parkinson's disease in those conditions. Yes, sir.
Right. So once you have diagnosed that the patient probably has Parkinson's disease, how do you go about treating them, and at what stage do you call somebody like me, the neurosurgeon, to say, consider DBS? If you could just elaborate on what is the normal treatment protocol and at what stage is surgery considered.
Okay. Probably I will go back to the slide once again, just few minutes, sorry. Okay, doesn't matter. So when to treat? That's an important question. Sorry. So till now, what we have, the golden drug is levodopa. Levodopa is the best drug we have for Parkinson's disease. So if you look at this study, there are in the 10 years back, there was one concept was there. So they believed that levodopa was not the best drug because levodopa was there for almost like 40-50 years. And when you stop the levodopa, the patients will have lots of dyskinesias or fluctuations like that. Fluctuation means the patient will have on, sometimes they will become within 3 or 4 hours off. So they thought that levodopa should not be the first drug to stop. So they started with dopamine sparing like pramipexole, sertraline, something like that. If you look at this study in Italy and Ghana, Ghana is from Africa, Eventually, they found that levodopa, the diagnosed Parkinson's disease very early, around 3.5 years, and they started levodopa. But they developed wearing off around 5 years and dyskinesias around 6 to 6.5 years. In contrast, in Ghana, Africa, because um, their medical system is not so good, they diagnosed the Parkinson's disease around 5 years, and they started the liver up around 6 years. But eventually, they also developed wearing off and dyskinesia around 6 to 7 years. So overall, when we compare these two groups, even if you start the levodopa early or late, they both develop dyskinesias. So levodopa, this proved that levodopa is not the culprit, not the cause for producing dyskinesias or wearing off. This is the disease process itself, the cause for the dyskinesias and wearing off. So other thing, lots of our patients think that they should not start levodopa. They will wanted to take less levodopa. Like probably I'll talk in Tamil and English. Most of the people will know that. நம்மகிட்ட நிறைய பேஷண்ட்ஸ் வந்து லியோடோப்பா எடுத்தோம்னாக்க உடனே வந்து அது தப்பு, 2 மாத்திரை 3 மாத்திரை எடுத்தோம்னா போதும், நிறைய மாத்திரை எடுத்தோம்னாக்க அது வந்து தப்பு அப்படின்னு நினைச்சிட்டு இருக்காங்க. பட் இஃப் யூ லுக் அட் திஸ் ஒன், இன் திஸ் ஸ்டடி தே ஷோட் தட் லியோடோப்பா வந்து இயர்லியா ஸ்டார்ட் பண்ணியிருக்காங்க, லைக் ப்ராபப்லி 1 to 2 years. And in this group of people, they started the other medication like levodopa illama, like pramipexole or selegiline or other dopamine sparing medications. If you look at that one, in the disease like yearly, if you start the levodopa, they require more levodopa after 2 years, 3 years, and they have lots of off and on. But if you see this group of patients, they had like they require more levodopa around 3 years, and they had off and on later on. But after 7 or 6 or 5 to 6 years, if you see this patient, those who are on regular levodopa, who start on levodopa earlier and on adequate dose, they have less disability. அதாவது அவங்களோட பார்க்கின்சன்ஸ் டிசீஸோட ப்ராப்ளம்ஸ் கம்மியாக இருக்கு. பட் those who are not on levodopa, they have lots of troubles, lots of disability when they are not on levodopa or when they are off levodopa. So it means levodopa is the best medication for our patients. And if you are don't think that the extra levodopa or excess medications is wrong. If you take less medication or if you are not on levodopa, that in a longer run it produces more troubles for you rather than adequate medications or more medications. So when we call Vishnavan sir, or when we call the neurosurgeon, when a patient is having lots of fluctuations, like if you take a whole day, if they have off period for more than 2 hours a day, or if a patient is on 500 milligrams of levodopa or more, not only levodopa, like if they are on 3 times levodopa plus something like pramipexole or something like selegiline, whenever other medications, you should take all the medications into account. So it's called as levodopa equivalent. So 500 milligrams levodopa irundaka, or if the patient is having more than 2 hours of off period, around 1 hour of dyskinesias, like morning 15 minutes, afternoon 15 minutes, evening 15 minutes, night 15 minutes, overall more than 1 hour of dyskinesias, it means the patient requires more medications or more medication adjustment or advanced therapies. So most of the patients, like they will come into 500 within after 4 to 5 years, they will be on almost more than 5 tablets of levodopa or 3 tablets of levodopa plus some other medication, pramipexole or selegiline, something else will be there. Obviously, they will be on 2 hours of off period, காலையில் half an hour, மத்தியானம் half an hour, evening half an hour. அப்படி பார்த்தோம்னாக்க எப்படி பார்த்தாலும் within a day 2 hours of off period and 1 hour of dyskinesia. If it is mild or moderate, what we need to take into account is whether all these things, the off period and dyskinesias, are troubling the patient or not, whether it impacts the quality of life. That is what the important question we need to ask the patient. Somebody will say that even like they will be like ஆக்டிவாக டெய்லி ஒர்க் போயிட்டு இருக்கிறவா இருப்பார். ஸோ அவங்களுக்கு பார்த்தீங்கன்னாக்க ஈவன் ஒரு half an hour or 1 hour ஆஃப் பீரியட் இஸ் வெரி வெரி difficult for them to manage because their quality of work is affected. Some patient வீட்டில் இருக்க 2 hours is fine. So it depends, it varies about each and every individual. So in that case, இந்த மாதிரி ப்ராப்ளம் இருக்கவங்கள இமீடியட்டா வில் ஆஸ்க் விஸ்வநாதன் சார் டு see. Yes sir.
Right. Right.
So if in case if a patient requires like this type of on and off, like if the patient is having troubles, so at the time we refer to Vishwanathan sir. Probably Dr. Vishwanathan sir will explain you a little bit about the DBS.
Right. Thanks, Dr. Vijay. So now, what is surgery? A typical neurosurgery is the patient is admitted, operated, and he goes home. But here, the process starts well before that. So after this detailed assessment, which Dr. Vijay has mentioned, he does a detailed charting of the patient, does a few tests, and then says, yes, this patient can be, beneficial for a DBS. We admit the patient, and one day before the actual surgery, the surgery actually starts. So we do what is called a planning MRI. The planning MRI is a very detailed MRI. Some sequences are specific for the procedure, and then we prepare them for surgery. Now, this planning MRI CD or DVD is taken onto a planning station software, and we do a detailed planning on the computer about where to put the electrode. Typically for Parkinson's disease, the area that we put the electrode is someplace called the subthalamic nucleus, STN. On the day of surgery, we go through, as I already mentioned, the patient is fully awake. So we give local anesthesia and fit 4 screws on the head, and we fit what is called a stereotactic frame. Now the stereotactic frame is fitted and the patient goes for a CT scan. With this CT scan and the previously done MRI, both are fused together by the software, and then we know exactly in sub-millimetric accuracy where that subthalamic nucleus lies. So this is all the planning that is done on the computer system. The patient is again wheeled back after the scan to the OT. Head is clean. Patient is placed on the OT table. There is a transparent sheet whereby the surgery can happen in a sterile fashion behind on the head of the patient. And on this side, the anesthetist, Dr. Vijay, the neurologist, the electrophysiologist, and all can be standing. And we can communicate with the patient, make the patient do, move his hand, move his leg, speak, move his eyes, and things like that. So the stereotactic frame is assembled on the head. A hole is drilled on the skull on one side first, and then the opposite side. And then we fit in some sort of implements to ensure that the electrode once placed stays in that place. So it sort of holds the electrode. And now this is called a microelectrode recorder, where a slender electrode is passed in 2 or 3 electrodes at 1 millimeter apart, and which can record the electrical activity inside the brain from that area. All that is meticulously recorded. So we see at what stage we had the good recording, at what stage we had, and then we send in currents through those electrodes and find at what voltages we got good response, what side effects happened, and things like that. So it's a detailed assessment of the patient in the operating theater. And then we finally put the electrode. Now that blue line and the red line are the planning that we did before the operation. And that whitish streak that you see on both sides, that is the artifact that comes from the electrode tip. As you can see, the electrode is sitting exactly where we intended it to be post-operatively. Then, so that means that after the procedure, the patient goes for another scan. We confirm that everything is fine. There are no complications. There are no bleeding, nothing of that sort. And then we bring the patient back, remove all that what is fitted on the head, give the patient general anesthesia, and put the battery in the chest wall and connect that with cables, just like the Chennai metro tunnels that go under the road. We have a tunnel that through which the cables pass up to this point in the head, and then we close everything up. And this is a post-operative flow. So we keep them in the ICU for about a day, not more than that. The longer they stay in hospital, it is not good for them. There is a risk of infection and things like that. We shift them to the room. We may just do a basic check on the device. Usually do not turn on the device immediately. And then we tell them how to maintain. If it's a rechargeable device, we teach the family how to do the recharging and things like that, and aim to discharge the patient as early as 3 to 5 days from the operation. So this is essentially about what the surgery means.
So one more question I have. What was the result of the surgery? Or like, how beneficial is this? Or how will you say that what is the outcome of the surgery?
All right. So let me again share. In this particular type of operation, the result is quite evident during the operation itself. In that sense, it is a very rewarding operation, if one can say that. Here you can see that Dr. Vijay is doing the testing during the surgery, and I will also pop in briefly. You can see there is a bit of a shake in the patient's hand. Okay, and movement. You don't need to be a neurologist to know that this is a trauma. And as the energy is being increased, we can see that the movements are a lot more certain, and the patient is able, the movements become more free. There is not much of tremor. And on the long term as well, there is good response. This is a gentleman who underwent DBS about a year or so ago. We've just temporarily turned off the battery. And you can see once the battery is off, he starts shaking. And as soon as the battery is on, that you can see the battery is on, and you can see how dramatic the hand. So the results of surgery, especially for symptoms of tremor, rigidity, that is tightness of the limbs, and the slowness of walking, the results are pretty good. Now, no amount about the possible complications as well. So major bleeding, coma, risk to life, and things like that are in the order of less than 0.5%. Stimulation-related side effects are a unique side effect of this particular type of surgery. As I mentioned, there are electrodes placed in the brain. Depending on where the current spreads to, the side effects can happen. This is usually temporary. So we can change either the electrodes through which the current is passing. Usually there are 4 electrodes or 8 electrodes on one side of the brain. So we can change the electrode through which the current is passing, or change some of the other stimulation parameters. Finally, infection is the most dreaded complication. Even if the patient has the wonderful post-operative improvement, unfortunately, if infection happens, the entire implant has to be thrown down into the bin. So therefore, that is something that is a two-way process. Both the treating team, patient, and family both have to work together to minimize infection. So that's about the results. We can also discuss a little bit. I think there are not many doctors on the attendees now. So I had brought a bit of technical information as well about the results. I will just show that briefly. So this is statistics. So this central line means anything that is in this side favors surgery and anything this side favors medical treatment. So for most parameters and most studies that have been done, international studies, surgery is definitely beneficial. This is shown in a much more easy to understand graphical chart that compared to medical therapy, where there is a 1% worsening, there is DBS. And the same thing as a chart that for most things like quality of life, which is very important. So one thing important to realize is DBS will not cure the Parkinson's disease, but help to control it. Much like insulin will help to control the diabetes and not cure the diabetes. So improvement in the motor scores, which I had mentioned, improvements in the activities of daily living, improvements in some of the charting that Dr. Vijay would do, increased hours of good mobility and things like that do happen. And from surgery. So there is to say the final sentence, there is scientific evidence that surgery works.
So I would like to add few more things in this one. So when as Sar said, I wanted to add some more earlier, but I missed it. So what is the advantage of DBS? And when you see this study, so it clearly shows that when compared to DBS versus the best medical therapy, this is one of the best studies all over the world they have done. Like almost like 300 patients they have done. So if you look at this one, overall, if you take a whole day, like the patients with DBS, they had improved like 4.5 hours of on time without troubling dyskinesias. So the patient had, like if you had like 5 to 6 hours of off period, they improved, the DBS improved the on time by 4.5 hours. And also it showed that the DBS, like 71% of the DBS patient had better than 32% of best treatment, whatever we say. So it is almost, DBS showed 40% better than the best medical therapy. Like if you say that if you are on 5 tablets or 4 tablets or 4 different tablets, that's called as the best medical therapy. What is the best treatment what we have for Parkinson's disease today? And other thing is when to do the DBS. That's an important question we always have. So if you look at this thing, like within like this is when we diagnose that the patient is having tremors, rigidity, or bradykinesia. This is the first 5 years. We can say that in the first 5 years, usually the patients like medications itself is good enough to control their symptoms. After 5 to 10 years, they will start develop the fluctuations. So we need to increase the medication. When we increase the medication, obviously they will develop dyskinesia. After 10 years, the patient will have some dysphagia, like freezing of weight, balance problem, falls, partial weight, and everything will have. So, what is the best time to send your patient for DBS, or when to select the patient for DBS? It means the best time is 5 to 10 years. That's the best time for selecting a patient. But it depends upon every individual patient. So I'll show you the next thing. If you look at this cartoon, like 10 years back or 15 years back, we thought that DBS is the lost treatment, which is when the tablets are not at all working. At that time only they advise DBS. So at that time, if you look at this one, the brown color is the motor symptoms like tremors, rigidity, or their slowness of activities. The blue one is the psychological condition, the overall Parkinson's overall well-being. So if you do a surgery around like a 10 years, something like that, so even though it gives benefits to the patient, but it improves the motor symptoms, but overall well-being and psychological condition is not improved. But if you do the surgery earlier, like around 5 to 7 years, something like that, so it improves the overall motor symptoms like tremors, rigidity, their slowness of activity, then overall their psychological condition and the overall well-being both are improved. That's why they have done a yearly STEM study. So in the yearly STEM study showed that we can do the DBS around when a patient is having 4 years of Parkinson's disease, and like when you increase this medication within 4 months of complications like off period, on period. So we can go for a DBS like 4 years or 4 months of complications. So the best candidates, who are the best candidates? Anybody who is having a Parkinson's disease, like tremors, rigidity, slowness of gait, freezing. The freezing which should respond to levodopa. But as you know, there are several other conditions like can mimic, or there are subtypes of Parkinson's disease like Parkinson's plus syndrome, or what we call it as a atypical Parkinson's disease, such as progressive supranuclear palsy, corticobasal syndrome, dementia of Lewy bodies. So these are all a subtype of Parkinson's disease. They may not respond well to levodopa. So whatever the Parkinson, we should first confirm whether it is a Parkinson's disease which responds well to levodopa, and they should have a good memory, because the condition which closely mimics Parkinson's disease, dementia of Lewy bodies, they will have lots of dementia. So that should not be there. And the secondary causes like drug-induced Parkinson's and other conditions should be ruled out. And the patient should have a fluctuations, like as I told you earlier, if a patient is having like off period for like cumulative off period, like 2 hours a day, like morning half an hour, afternoon half an hour, evening half an hour, night half an hour, total 2 hours, and troublesome dyskinesias for more than 1 hour, and age less than 70 years. But if a patient is good, or they are really fit, and they are having no major problems, so in that case, we can select patients up to 75 years. And there are some studies show that even like more than that also can be taken if the patient is really good and the patient doesn't have any problems. So age less than 70 years is one of the criteria, and the Parkinson's disease should be like 4 years of Parkinson's disease, and with good medication, they have lots of on and off for within 4 months, we can go for DBS. So this could be the one of the criteria. So these are all the best candidates for DBS. Yes, sir. You want to add anything else, sir? You are mute.
I think at this point, I'd like to answer one of the anonymous attendees' question. Wrong placement of electrodes can also be a complication. I think it is the way I would like to answer that question is, if you had seen that initial video, what I was saying there, if a typical operation has about 10-15 steps, DBS has about 100 different steps. Each step can go wrong. And when it goes wrong, it can wreck the whole operation. Essentially, the electrodes can fall in the wrong location. The way to minimize that is to have checks and balances. One is a team that understands itself, a well-oiled, sort of machine, having the right protocol on the MRI, because in certain MRI machines, the SCN may not even be seen. Then we'll have to let the computer decide where the nucleus is. So therefore, there are many small things that are important, and everything adds up to a successful operation. The stereotactic frame that we use, if done properly, the error should be minimized to less than a millimeter. So you cannot totally be in the wrong place unless you make certain calculational errors and things like that, which are technical. Not that it has never happened. So therefore, at every step there are checks. So the final check is the CT scan that is done after the procedure to check where the electrode is, and then the making sure that the we use all the gadgets and implements that are given along with the. So there is something called a stim lock that Medtronic provides, and different companies have different things which help to keep the electrode in place. If we use all of this, then we sort of reduce the chance of things going wrong. And even if things go wrong, then we are able to identify it early. And before the patient wakes up from surgery, we're able to ensure that the electrode is in the right place. So that is the way I would answer that. And now to Dr. Vijay, now after surgery, does it mean that patient can totally, get off Syndopa and DBS will take care of their treatment? And can you sort of elaborate on that? That seems to be a common question that all patients usually ask. And along with that, you can probably touch upon that other question that has come, asking, whether how you would give the Syndopa typically. Your slide that seems to have provoked a question. Yeah.
So probably I'll just show them once again the slide, then I'll go back to the question again. First, I'll start on this one. So it is important always, if a patient, like for example, if a patient is on levodopa 3 times a day, just for example, the first dose if he is taking 8 o'clock, usually we advise levodopa to be taken half an hour before food. Sometimes the patient may be on like 5 times or 6 times a day the levodopa. In that case, it is very difficult to take half an hour before food. In that case, we advise them to take half an hour before food and take 1.5 hours after the food. So why it is important? Because most of the Parkinson's patients nowadays, they don't know, because if we take levodopa with the food, the absorption of the levodopa is reduced. So levodopa should be taken on empty stomach because the food competes with the absorption of the levodopa. And as I told you earlier, if they take levodopa at 8 o'clock, like half an hour before food, and the levodopa usually will take half an hour, 15 to 30 minutes for everybody to act. So it will take around like 8 o'clock. If they take the levodopa, it takes 8:30 to start to act, and the peak will be around 10 o'clock. And slowly after that, around 12 or 12:30, it will slowly, the blood levels of levodopa will fall down. Around 12:30 to 1, it will go down. So if they take the next dose of levodopa at 1 o'clock, so if you think that this is 12:30, they are completely off. They have lots of tremors, lots of rigidity, so lots of slowness of activity. So during this off period, not only the motor symptoms like tremor, rigidity, and the slowness will worsen. The non-motor symptoms, what we call it as when the levodopa is going down from the, lots of patients will become anxious. They will be really like, they will have palpitations, they will have sweating, they will have really like they cannot, they will get angry, or their mood, they cannot think properly. So this will also will come into the effect. So which we call it as a non-motor fluctuation. When the levodopa is not working well, the patient will be confused, they will be anxious, they will be angry. So sometimes because of the lack of dopamine, the body will be stiff. So they can also have some breathing difficulties. Also, they will have some frequency of urination. All this can occur when the levodopa is less. So it's around 12:30, the off period starts. Around 1 o'clock, if they take the levodopa, As usual, it takes at least half an hour to act. So around 1:30, it will act. So if you take it in this picture, 12:30 they are becoming off, and they are becoming on around 1:30. So that the whole off period is, we should calculate from 12:30 to 1:30. So it is 1 hour of off period. So 1 hour of off period in the morning, 1 hour of off period in the evening and the early morning. That's why how we need to calculate. There are other things also. I'll always inform my patients what are the factors influencing the wearing off, like levodopa when taking with the food, high protein food, and constipation. All these things will interfere with the absorption of levodopa. Coming back to the our question, like Dr. Vishnu asked this, whether if you do a DBS, whether all the medications are completely taken off. That's the first question all my patients will ask. The answer is, if you do a DBS, DBS is like another best symptomatic therapy what we have for our patients. Like how the levodopa is working, the DBS will also work like that. This is a symptomatic therapy rather than a cure. So when you do a DBS, the DBS will work as a improves the Parkinson's symptom. With the help of the DBS, we can reduce the medications like up to 40 to 70% of the patient, because as we know that everyone is different, and like how when we are going to do the DBS, like if you do a DBS earlier when the patient is really good, you can go up to 70% of the improvement. When you do the DBS later on, when the patient is having lots of troubles, like a little bit of advanced Parkinson's disease, they require a little bit of more medications. So probably 40 to 50% of medications we can reduce. So, but still, if you are on DBS, they require some adequate, because levodopa has some good beneficial effect on Parkinson's disease. So we should take all the good benefit from the DBS and all the good benefit from the levodopa. So that's what the best treatment offers. That's what the best way of treating the patients after the levodopa, after the DBS. So we may also reduce not only the levodopa, we may reduce the pramipexole or rasagiline or other medications also. So overall, everything will come up to like less than 50% of the earlier pre-DBS dose we will reduce. The important thing here is we need to be, when you reduce the levodopa, when you reduce the dopamine sparing agents, automatically the dyskinesias will reduce. And we also have lots of techniques, like lots of programming options we have. So to reduce the dyskinesias or improve the tremors or improve the slowness, everything we have some techniques. There are more than like 100 types of like programming options we have. So we use these programming techniques to improve the symptoms. So when talking about the programming, so I would like to, shall I talk about the programming options also, sir?
Yeah, if we could just break it a bit, there are, I think Mr. Vignesh is asking a question about the success rate of DBS in Chennai, India, USA. Where is it done with utmost care? And whether there are any better alternative approach instead of DBS. Now, if I could try to answer these three things before we touch upon programming, we can talk about how we take care. We will not be able to talk about how is it done elsewhere. We can say that at our institute, we work as a team. As you know, both of us are well trained in what we do, and we are not the only two people who are part of that team. So there is a team of speech therapists, physiotherapists, rehab specialists, who all see the patient, as a team, and then it is the pre-operative diagnosis, the pre-operative pre-surgical workup, the charting, and things like that happen as it is done in the best centers in the world. But we will not be able to comment on how it is done elsewhere. In India, as such, there are various other centers that do DBS regularly. In South India, Sri Chitra Tirunal which is a government institution in Trivandrum, does quite a lot. So the parameters that we have told you now, keep that in mind before you judge whether people are taking care or not. So that's a judgment call that Mr. Vignesh has to make. About any better alternative approach, at the moment, DBS is as much in the front line as far as possible in terms of the technology has progressed. The DBS, as nanotechnology and things come in, the implements will become smaller, miniaturized, and things like that. But we are not there yet. In the future, maybe there would be, genetic alterations that is possible, so that we can detect beforehand that this person would develop Parkinson's disease when he's 50, and given a medication early on in life and change it. But though that is all still in the realm of science fiction. So as things stand, whatever medicines Dr. Vijay mentioned and about the surgery that I mentioned is what is clinically approved and available anywhere in the world. The cost of it, the various brands are available, but broadly the two types of batteries that are available is the non-rechargeable, which you can think of as the ever-ready battery, the torch battery, where you put it in, it works till the light burns, and once the battery runs down, you have to put a new battery. So that is the lower cost battery. So the cost of that particular surgery would come to somewhere around 8 or 9 lakhs. The more advanced battery, that is the rechargeable battery, you have to place something on your skin over the battery, and the recharging happens through the skin. So that battery is smaller and it lasts much longer. The non-rechargeable battery life is about 3 to 5 years. There are different brands which offer even up to 7 or 8 years. The rechargeable battery can last up to 12, 15 years, or some people claim even 25 years, but nobody knows for sure. But it is definitely longer than the non-rechargeable. So the cost of that surgery would come to around 13, 14 lakhs or so. And it is covered by insurance. Right now, the IRDAI, Insurance Regulatory Authority, has said that DBS surgery should not be rejected. And if you have insurance, that would cover it as well. So now, having broken that monotony,
so,
now let's...
One question I would like to add. So when he has brought the question of what are the other treatment options we have, I like to just give some more points. So what are the other treatment options we have? There are, like, internationally, if you take it, there are 3 good, like what we are talking about, the advanced treatment options. One is the DBS. Second is apomorphine. Apomorphine is there for almost more than 30 years. There are 2 types of apomorphine is available. If you look at this one, just I'll share the screen. Okay. Yeah. So apomorphine is there for more than 30 years. Like, one is like our insulin injection. Whenever the patient is becoming off, at the time we give the apomorphine injection. Like, apomorphine works in like between 10 minutes, like 10 to 30, 20 minutes. It immediately brings the patient to on. The next one is apomorphine continuous infusion. Like the insulin syringe, but it is not available in India, but probably like within like a couple of months, they will bring the insulin like injection. But at present, what we are giving, the apomorphine, whatever is available in India, is just like an injection, just to take it and put it in the subcutaneous in the skin. So if you give the apomorphine injection, within 15 minutes, the patient will become on. When the disease progresses, like in moderate to severe Parkinson's disease, even though if you take levodopa, the levodopa takes 1 hour to act, or sometimes the levodopa may not act at all. In that case, we use this apomorphine as a rescue therapy. Immediately, if you give, the patient will be on, they can go to their work, they can go to a meeting, or they can go to some family members gathering like that. But there are other options also there. This is the apomorphine infusion. We can also use the apomorphine infusion just 24 hours, just putting the small needle in the abdomen, something like that. The next thing is what we have is the levodopa infusion, giving the levodopa infusion through the intestines, like this, it will be like this. So, but this levodopa infusion is not available in India, pretty expensive. Like it is every year, it is like 4 to 5 times the cost of the DBS, like for 50 lakhs, 60 lakhs, something like that every year. But it is still not available in India. So these are the advanced therapies available in India. But when you compare between all the three available advanced therapies like DBS, apomorphine, and intestinal levodopa, the best thing still whatever we have is the DBS. That's the best thing we have. When we start the levodopa infusion or the apomorphine pump, I showed it in this picture. When a patient is not a candidate for DBS, like the patient has some problem in the brain, he is not having some troubles, tumors in the brain, or the patient is more than 75, 80 years, or the memory problem is they have lots of hallucinations, or they have lots of other depression or severe problems, something like that. In that case only, we prefer, if surgery is, there doesn't want to be a surgery of the brain, in that case only we prefer to do a alternative, the levodopa infusion or apomorphine. But if you look at the, because this intestinal levodopa is out of question in India now, the only available treatment is apomorphine and DBS. When compared to apomorphine and DBS, apomorphine is a good drug actually. But if you take a long term, like 10 years of studies, most of the patients, like, because apomorphine you need to prick the skin almost daily to give the infusion, and you need to prick it in the, we cannot give it in the same place. We need to change the place, like this, every place like this, mainly in the stomach or in the skin, something like that. So if you put it daily, it's a pricking and it will be like pain also is there. So most of the patient, after 4 years or 5 years, they will stop apomorphine and they will try to change to some other advanced therapies. Mostly they prefer to change to DBS. So if it is in a young patient, but in advanced therapies, like in advanced stage, we prefer to give, when a patient is not a candidate for DBS, we go for apomorphine. But if you ask me which is the best treatment I can offer for a less than 75 Parkinson's disease, or when they are good candidate, if it's going to be my family member or my father, I would prefer DBS. That's the best option we have. Yes, sir.
Right. So that's pretty clear. Now, can you also elaborate on this programming? What is programming? And how do you do that? How often the patient needs to come for it, and things like that.
Yeah. So when you talk about the programming, usually it depends upon every place. Like immediately after the surgery, we can start the DBS like slowly on the day of surgery, or depending upon the patient, we can plan like a week or two how the patient is responding. The wound has to heal. So it depends upon every patient. We select the patient, we decide prior to the surgery itself when we want to start the DBS on. So usually around 1 or 2 weeks, we'll start the DBS on. And slowly, depending upon the patient, how they are tolerating the DBS, because this is something new to them. So we will initially go slowly, like every week or every 2 weeks, depending upon the patient condition, or if they are from somewhere else, if they are traveling from like a 400 to 500 kilometers. So in that case, we can plan, we can have a secondary options, like we have how to, we teach the patients how to increase by themselves. So we can bring the patient every month, something like that we will usually plan. So slowly, like we increase the amplitude, like first we start with 0.5, slowly we'll increase to 1 and then 1.5. We can go up to like 4 to 5 voltage amplitude we can go. When we increase the amplitude, what we'll do is try to reduce the medication slowly, because when the patient was probably they will be taking the levodopa for almost 5 years or 10 years with levodopa and other medication. If you take the medications immediately, the body and the brain will think that something was taken from them. Like if you are having like 1 lakh rupees, suddenly if I take you the 1 lakh rupees from you, will you give it to me immediately? No, you will feel that, oh my God, something is gone. So if I ask you like 5,000 rupees, you will say, yes, I'll give you. The next day, after 1 week, I will ask you another 5,000, 10,000 rupees. You will give. But at the end of the day, if I take like a 60,000 rupees, will you feel the difference? No, because you are giving small amount. Like that, the body is used to the medications for years. So we should not take the medications immediately. So the body will have something, something was taken from them. So they will feel more depressed, or they will feel more sudden off, something, all these problems can occur. So slowly when you increase the DBS will take care of the baseline Parkinson's disease. So like if the patient is on 5 times levodopa, or sometimes 4 times levodopa plus 1 pramipexole, 2 pramipexole, slowly we'll take out 1 levodopa, 3 times and 2 pramipexole. Then I'll increase to 1. Then I'll reduce the 1 levodopa, 3 times levodopa, and take 2 pramipexole. Then 2. Then when increase to 2 voltage, I'll take 1 pramipexole, then 2.5. Slowly, I'll try to maintain with 3 tablets or 4 tablets of levodopa. The important thing is the quality of life of the patient. If the patient is doing a surgery yearly, we have lots of patients who is maintaining well with DBS alone, without levodopa, completely off levodopa. But you know that Parkinson's disease is a progressive disease. Like over years, slowly it will progress. When it progresses, they may require over the years, they may, even though initially they are completely off levodopa, at some point of time they may require a little bit of increase in the stimulation. And slowly they may require a little bit of 1 tablet, 2 tablets, 3 tablets of medication. So increasing the medication is not the issue. Overall, how we are managing the patient's quality of life, how we are keeping the patient happy. This is called as a patient-centric. The patient is important. The patient-centric approach, like the well-being of how we are taking care of well-being of the patient, individual patient, how we are making the patient to have a normal life. That is important for us. So that is approach for a DBS patient. So we will adjust the medication a little bit here and there, and we'll make the patient to do all his activities, let them go back to their work, continue their work as like without. If you take 100 patients, 99.9% of the patients, they will say that after the DBS, they will say that their disease has reduced at least 3 to 4 years prior to what the DBS was done. They will go back to the state of 4 years younger, or 4 years better than the state what they are on at that time. So it is very, very important to first initially we'll call the patient like to find out what is the best dose and best stimulation, like DBS settings. So we call the patient something like once in 2 weeks or once in 3 weeks, depending upon where they are and how the condition. But once the disease, we found out what is the best settings and the best medications. When we found out everything clearly, probably we can call the patient once in 2 months or 3 months, depending upon how the patient condition behaves. And also we always give some settings like a range. We will have some room. So we will at the time we will teach the patient how to adjust by themselves. We'll coordinate with them, and from the home itself, the patient will advise them how to adjust the stimulation. So probably they can come once in 3 months, something like that. Do you want to add anything else, sir?
Yeah, I mean, nothing much except to reiterate that the words that the attendees should have listened here was slowly, 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 and gradually. So the main thing is that the patient and the family members should have their expectations correctly. That it's not that surgery was done, we spent so much money, with 1 month, it's 2 months, still he's having tremors and shaking. There is a reason why we are cranking up the stimulation slowly and bringing down the medicine slowly, so that you don't get additional side effects, and additionally your quality of life doesn't suddenly remarkably worsen at the time we're trying to get the stimulation parameters correct. So slowly, slowly, gradually. That's my take-home message from the programming part of it. Now, we've learned quite a lot about what is Parkinson's disease. Now, briefly, we will touch upon 2, 3 other conditions and then go to some of the questions that have cropped up at the end. Now, can you explain a little bit about what is essential tremor? The initial video that I showed about Mark Roberts, the heating engineer in UK, he had essential tremor, quite a lot of shaking. Can you explain to us what is essential tremors and how DBS can help?
Yes, sir. The essential tremor is like there are several types of tremors are there. Like if you take essential tremor, dystonic tremor, drug-induced tremor, or patient can have like a task specific task they will have tremors. There are several types of tremors, but the most common tremors are the essential tremor, or what we call it as a familial tremor. So the patient's father or grandfather or anybody grandparents will have their tremors. Subsequently, the father, son, everybody like familiarly they can have tremors. But this essential tremor, usually when it starts, it will be mild, maybe one hand initially. Within few months, they can have tremors, both like this very mild. But when the disease progresses like 5 years or 6 years, 10 years, they will have lots of tremors. So the important point is whether what we should take into account, whether the tremors are interfering in their day-to-day life activities. Like if a male, whether they are able to shave or they are able to hold a spoon and cut the food and bring it to the mouth properly, or when they are holding a cup of coffee, whether they are able to bring the coffee properly or they're spilling it, or when they are doing their work like buttoning or while writing, whether all these things are interfered or not, whether they are able to do their day-to-day activities without any trouble. So that is the important thing what we need to do. So if they have troubles, we will always try to start the medication. Like initially when the disease is very mild, we will give one tablet, propranolol or something like that. Usually they will respond okay. Then when the disease slowly within 6 months to 1 year, the disease will progress. We will add other medication 2. Then we'll add other medication 3. So sometimes when we add or increase the medications, the patient will cannot like whatever the best treatment we offer. This type of essential tremor at some point of time will not respond to medication. At least if you take like 1,000 patients, only 30 to 40% of patients will have some benefit with the medication or for some time. After 5 or 6 years, depending upon every individual, at some point of time, these medications will not help. So as you see, Dr. Vishwan's patient, so that patient had lots of tremors. So I will show you another patient, which is mine. I have seen a couple of years back when I was in Ireland. I'll show you this one. Yeah, this gentleman. You can see. Yeah, so you can see there is tremors, lots of tremors. So you can see he has how bad is his tremors. He cannot do anything with these tremors. His handwriting is bad. He cannot do anything. His day-to-day activities is really troublesome. In another patient, if you look at this gentleman, similarly, I saw him in India. So I'm trying to bring out the tremors. You can see it's more on the left side. This is another type of tremor, most likely to be a dystonic tremor. See, whenever he holds a pen or whenever he is holding something up, it is difficult for him. So these type of tremors, when they are not able to do their activities of daily living, then if you take Usually these type of tremors will not respond well to medication. The best treatment what we have is DBS in these type of patients. When they are able to do their activities with medication, we will try to maintain them with good medication. But when they have lots of troubles, we'll always prefer them to go for DBS. DBS is the best treatment of option we have for these type of essential tremors. Sir, do you want to add anything else, sir?
No, I mean, you've covered most of it. And just want to pick a couple of questions that are related, which I've answered on the chat button as well, is how to differentiate between Parkinson's disease, essential tremor, and one more condition that we will discuss following this as well. Is it treated with levodopa? No. For everything, levodopa is not the only drug. There are various other drugs that can help. So that is the reason why somebody like Dr. Vijay Shankar, who has the experience to distinguish between some of these things, which can sometimes be very difficult to discern. Sometimes two things can be together. Why this is important to discern is, one is to find out what medicine can work. Is there a medicine in the first place? Because there are some types of Parkinson's disease, the Parkinson's plus syndromes, which he had mentioned, for which really we can give medicines, but there is nothing really that really works other than supportive therapy, physiotherapy, and things like that. Therefore, the important thing is to diagnose it correctly, so that for essential tremor, the electrode is placed in a different area, and that can sometimes lead to dramatic improvement. Again, most of the times, I should say. Body imbalance can be part of this, part of that. So it's too vast. I mean, we cannot cover the entire neurology or movement disorders neurology in this webinar, but it's too vast, and that is why somebody who with experience in this subspecialty is needed to look at the patient closely. Do the patient require therapy after DBS? The patient requires therapy both before and after the DBS. In Ramachandra, we work closely, as I said, with the speech therapist, with physiotherapists. There are various parameters that can be used in DBS that can improve the speech or worsen the speech, improve the walking, worsen the walking, and things like that. In fact, we are doing currently a research project in Ramachandra on various simulation parameters that can help with speech. So towards the end of this, Dr. Vijay will also mention about the upcoming webinars where we will involve our team members as well, exclusively to talk to you about what sort of therapies are helpful. Now, let's move on to probably the last part of this webinar. Can you explain to us about what this condition called dystonia is, and how that can be treated?
Yes, sir. The dystonia is something like what we call it as a abnormal movements, or like a twisting movements, or like a body is turned like this, the neck is turned like this. Sometimes because of some subtle dystonia, they can also have like a dystonic tremor of the neck or hands, something like that. So we call it as two different types of main dystonia. One is a focal dystonia. Focal dystonia is just involving the one part of the body, like hands, neck, or legs, something like that. The other part hand is generalized dystonia, like involving the neck, the whole body, or neck and body, face, everything involving like eyes, mouth, everything. So this is called as a generalized dystonia. If you look at this picture, I'll show you. So this is, there are several types of dystonia are there. One is that like a neck is bending forwards, backwards, to the sides, like what's called as a torticollis, and to the lateral side, which is called as a lateropolis. So depending upon the involvement, we have lots of troubles in this type of patients. So when it is mild, we usually treat it with their medications. Or if it is required, we give something like a Botox injection. But when the disease progresses, these medications and Botox are not adequate to control the symptoms. At the time, they require DBS. Probably if you see this patient, one of my patients, you can see this one. So you can see she's having a neck is going backwards to the little bit of side, and even the hands was also going to the sides. So she could not stand properly. She has not a primary dystonia; she is having a secondary dystonia, but still we can see the overall the body is involved. So these type of patients may benefit even though if I give Botox or medication, they require lots of medications because it is difficult for them to manage this type of severe dystonia. So in this case, we prefer to do DBS. Probably Dr. Vishwanathan sir will discuss about what are the areas and how the DBS will help in dystonias.
Yeah. So for generalized dystonia, as Dr. Vijay has mentioned, especially if there are some specific genetic mutations, those are the DYT1 mutation and things like that, is where we can tell the patients that you have a severe condition for which there is hardly any medication available, but DBS, we can promise that can have quite a good improvement in the vast majority of patients. If it is secondary dystonia, the results are not that great, but still DBS can be tried. Now, I will try and show you a video that would explain better than my words. So this is an elderly gentleman, one of my patients from Delhi. So he is, as you can see, middle-aged. This is how he has been for the last 30, 40 odd years, to lie down without shaking. This is his existence all the time. So I had operated him in Delhi. This is his own self, he has taken this video about a week after surgery. So that probably speaks quite a lot more than any videos. You can see simple things like shaving and things like that, which are very difficult before, can become quite easy. And this is about a month after we started the programming. As you can see, still there is a bit of twist if you look at him closely, but he is loads better, loads better. So for conditions like this, we can help having happy patients at the end of the line. Our planned, I think there is an anonymous attendee and a Redmi who I suspect could be the same person. They could just point out if they are not, because the clinical sort of thing which they have mentioned in their 3 posts are pretty much overlapping. Now, from what I understand, the age is not certain, but his father has had a DBS surgery. There are 2 or 3 questions. One with respect to encarate chrono, quetiapine, urinary incontinence, and redo surgery. Now, they've had sort of redo surgery, and clinically, things are movement-wise are better. I will answer the question about the like that. So the subthalamic nucleus, which I suspect is the commonest location that is targeted, and we'll discuss, is a small area in the brain. But in that small area, the area that we target is even more smaller. So there are other areas where if the electricity passes, which is called the limbic part of the STN, which is our primitive most things like fight, flight responses are all encoded there, and that circuits pass there. If that is stimulated, maybe that some amount of these sorts of anger and things like that. More importantly, things like confusion, because what happens is these patients are kept fasting for surgery. when they don't have the morning medications, by the time they come, it is early morning or afternoon. By the time the electrodes are put in and testing is happening, it is quite tiring for them. So sometimes that could be some confusion and things like that. For the rest of the questions about hallucination, quetiapine, incontinence, I think Dr. Vijay is the right person to answer.
As they have mentioned earlier, he was he's an elderly gentleman, but he also had like a frequent urinary incontinence. But this can happen in two things. One, when the disease is advanced, Parkinson's disease can also have urinary urgency, frequency. Sometimes patients can pass there because they cannot walk in the night and they cannot go to the washroom. So there is a chances of urinary accidents, like what we call they pass the urine with the cloth itself. So this can happen in Parkinson's disease itself, or sometimes when they doesn't know whether. Usually Parkinson's patients knows that they are going to pass the urine. They will say that I cannot go to the washroom, I cannot control, that's why I'm pausing. But sometimes it occurs during the night. Possibly that could be a underlying possibility of a seizures. Seizures can present with their urinary incontinence. Sometimes not only the jerks, the what we call as a seizures, but the seizures can occur even without the jerks. That could be another reason. That's why they are started on inquiry. But still, if he has a underlying urinary incontinence, we need to evaluate him thoroughly to see what could be the other reasons for, other than the Parkinson's disease seizures, what else could be the reason for the urinary incontinence. And he has mentioned that he was stopped the quetiapine and the hallucination has started again. And not as bad if the hallucinations are mild and if it's not really troublesome for the patient. I will not start the quetiapine again. But if the hallucinations are really troublesome, yes, we need to restart the quetiapine, and we need to find out what could be the other causes for the urinary incontinence. So I think we would like to see the patient in person. That could be because we can evaluate the patient, we can examine the patient, and we will come to a conclusion what it is, and we can offer the best treatment for that. The next question is, some attendee has asked, my father has Parkinson's disease and I'm 31 years old. My right hand shows tremors very rarely, like once in a month. Should I get tested? This is a little bit of a complicated question because, as I told you, two things. One, there are several genetic factors can produce Parkinson's disease. There are lots of patients, like when their father or grandfather has Parkinson's disease, may have genetically, they will develop Parkinson's disease. But in the other hand, if a patient is father is a Parkinson's disease, their son can have a dystonia, or they can have a essential tremor, or some other sort of tremors. So both can happen. One, it could be direct Parkinson's disease, or it could be some other reason which can present like a tremors. The other thing what he has mentioned is he has a tremors like a once in a month, rarely. So that could be like probably it could be a part of anxiety or stress, or we need to find out what is exactly and how bad is the tremors. We'll do some tests like clinical examination to find out what is the type of tremor and whether this tremor requires further test. That's the first question. If the tremor requires further test, we need to find out what is the underlying disease. Sometimes even if you get frightened or if you are stressed, even anybody can have some tremor. In that case, we won't advise them to do further tests. We'll tell them, don't worry, just go and enjoy your life. But if he has some troubles, then we'll try to do some other tests to find out what is the underlying disease, and we'll try to examine and further test required. Yes, in that case, we would like to examine you first to find out whether this tremor is a normal physiological tremor. In that case, no need to treat, no need to test further. If it is something else, maybe a early sign of something else, some other diseases, yes, we would like to do some tests to find out what is the underlying disease. That would be the best way to approach this problem. I think overall we have covered all the questions.
Yeah. So if there are any other questions or anybody has anything, please either raise your hand or in the event that we don't have any. So thank you to all the enthusiastic participation, interactive discussion. There were really quite a lot of questions, quite detailed. So we thank you for this participation. We also thank Parkinsons.co.in and Medtronic for facilitating this webinar. And I think before we close, we should Dr. Vijay mention about the next upcoming webinars from the movement disorders. Would you like to tell them when it's likely to be and what it is
So at
likely to
least like
cover?
we are planning to keep it in next 2 weeks, something like around 27th of this month. So this is mainly for Parkinson's disease patient who is having troubles in walking. The physiotherapist will explain about gait therapy, what all the physiotherapy that requires, and we also have a panel of speech therapists. They will explain about what all the other speech therapy techniques which can improve the speech. So this is going to be, because this is a very, very important session, because all the Parkinson's disease patient requires good speech therapy and physiotherapy. Because whatever we talk about the medications, which is just a symptomatic therapy, the exercise is the only important disease modifying. What do you mean? This disease modifying means is the only thing which can slow the progression of the disease. The Parkinson's disease will stay same if you do a good exercise and if you do a good really daily exercise. That will be really helpful. So this is very, very important for all the Parkinson's disease patients. So please follow us, and we have a Facebook page like a Parkinson's disease of Tamil Nadu support group, Parkinson's support group of Tamil Nadu. So me and Dr. Vishnu sir is running this Facebook page. So we have lots of information. We daily post whatever the new information we have for the Parkinson's disease patient. If there is some free courses, free classes for Parkinson's disease like physiotherapy, speech therapy, and if there is some new information about the Parkinson's disease, we post it there. So if you want to learn, just join with us. And if you have any comments about what could be the next webinar or what all the topics we should touch, or if you have any other suggestions to us, so please join the Facebook page Parkinson's Support Group of Tamil Nadu and give us some suggestions and feedback. Anything else you want to
Yeah,
add, sir?
I would actively encourage anybody and most of the people who are asking all these questions to attend, to enroll into that group. We have other than, I don't honestly actively post that much as Dr. Vijay does, but there are people from all around the world who post actively in that group, though it's supposed to be a Tamil Nadu group. So people, there is activity. You can learn a lot more about primarily Parkinson's disease and generally about most of the movement disorders. And at all times, we are available if there are any specific and personal questions or patient-related information. So once again, thanks to everybody, and we will close this session.
Thank you all for